All right, so we'll proceed. It is Wednesday. Good evening. Today is June 17th, 2020, and it is 5:30, and I am announcing the Budget and Finance Committee of Central Health. And as the chair of Central Health Board and at the request of Treasurer Oliver, I will be acting as chair for this meeting of the Budget Finance Committee in place of Chair Oliver, who is traveling to an event out of town. Chair Oliver is joining us via telephone as a passenger on her drive. As a quorum of the committee is in attendance via our video conference, I would like to call to order the meeting of the Central Health Budget and Finance Finance Committee. Is Yvonne or Jana on here? Yvonne.
Hi.
Do we have any people who have signed up for public communication?
No, Madam Chair, we have no members of the public who have signed up to speak.
Okay, Yvonne, since we have no members who have signed up to speak, then we will move on into our agenda. We will now proceed to the agenda. We will be taking the agenda out of order this evening in order to address a scheduling conflict. Item 5 will be taken up second, and items 2 through 4 will be taken up together after that. So the agenda order will be 1, 5, items 2, 3, and 4 together, and then item 6, and then item 7. So agenda item 1, approve the minutes of the March 11th and May 20th, 2020 meetings of the Central Health Budget and Finance Committee. Members? I see, yes, Manager Bell?
I would like to move that we accept the minutes of the, oh my goodness, can't find it. Okay.
March 11th.
Yeah, March 11th and May 20th, 2020 meetings of the Central Health Budget and Finance Committee.
Is there a second?
I'll second.
Okay, Manager Zuniga, yes. So we have a motion by Manager Bell and a second by Manager Zuniga. All in favor, say aye. Aye.
Aye.
Opposed, same sign. Okay, any abstaining? I'm not seeing any opposition or any abstaining. The motion passes. Thank you, members. We will now move on in our new order to item number 5. Discuss and take appropriate action on executing a lease agreement with the Kuchera companies for additional space at the Atrium Office Center, 8701 North Mopac, to house the Central Health Eligibility Call Center. John Morgan and Kit Abney-Spells will be presenting. Please proceed.
Thank you, Chair Greenberg. This is John Morgan. I will kick us off and very quickly turn this over to Kit Abney-Spells, who is our Senior Director of Eligibility Services, who you all have heard from many times. Kit, there was a presentation and a memo provided in advance. Kit will be sharing her screen for the presentation, so we'll let her pull that up while I just finish my quick comments. Tonight, you're going to hear about our ongoing work related to the Eligibility Call Center. I'd like to acknowledge up front that we have really had a great partner for a number of years in United Way, helping to perform this work. As I've mentioned in a few prior meetings, United Way informed us earlier this year that they intended to not renew their service agreement with us as they shift their focus to new strategic priorities for their organization. But they've been just stellar partners in helping us plan our transition over the past few months. Excuse me. I'd like to try to just tie this back conceptually very quickly to the recent strategic planning discussion that we had regarding our systems-based planning approach and the different components of our delivery system, as well as to our access to care initiatives and what you'll see in our budget conversations and heard last week related to our FY21 proposed planning priorities. As you all know, eligibility services is an incredibly important aspect of our overall system. It's typically the first place that our patients and our enrollees encounter our system, and and interact with our employees. And it's a key aspect of welcoming patients into our system, as well as making a lot of the back-end functions run smoothly. A lot of the different services that we provide, whether it's pharmacy, a highly functioning eligibility services system. And part of the strategic priorities moving into FY21 that you'll see from us in terms of our transformational operational initiatives that you heard about last week, transitioning this call center to an internal function really presents us with a lot of great opportunities to enhance our interactions with our patients, learn from our patients as we're interacting with them, and hopefully get better at addressing and responding to their needs in real time. And that's part of what we're wanting to build strategically as we're going into FY21. So there are a lot of components that go into standing up a call center function. We have to have this service operational by October 1. Kit's going to go over the overall timeline. Tonight, we're asking for action from the committee to recommend to the full board, more specifically, authorizing our CEO to negotiate and execute a lease agreement for this eligibility call center space. Last comment, I would just like to acknowledge our colleagues. There are a lot of folks on this call that are not presenting tonight. It really takes our entire team to pull something like this off, whether it's Stephen negotiating the lease, joint tech specing out the space, Kat Boone Bush is working on our furniture and equipment requirements. Kit is certainly taking the lead on all of this, but the process that Mike has put in place really helps us really come together as an organization and get large initiatives like this off the ground smoothly and taking into consideration. Should also mention HR, obviously, filling these positions moving forward. It really takes everybody to move this type of work. So I'll turn it over to Kit, and I'll certainly be available on the back end to help answer questions.
Thank you. Kit, please proceed.
Good evening. Thank you, Board of Managers. Obviously, this is a final version of our presentation. It is not a draft. Before we sort of launch into the lease, I did want to just sort of level set you on kind of currently the operations with United Way. And as John said, the United Way of Greater Austin has been our contracted vendor since October of 2009. They've been a very strong partner and served our clients well. And as John mentioned, eligibility being sort of that first front-facing place for our clients, the call center is really that very first touch point, often points. The call center functions today as an individual wanting information in general about coverage programs. They provide screening, Anybody calling, they will screen them for eligibility. And if they are eligible, we'll then schedule an appointment for them, again, pre-COVID, I should state, to meet one in our offices in order to apply. But then they also do things like answer benefit questions, provider questions, pharmacy questions, a whole host of things. I've provided you some metrics just over in our last fiscal year and the current fiscal year. And one of the things I did want to point out to you, as you can see, as United Way has been making this transition, it has been a challenge for them as they have lost employees. Rather than rehire new FTEs into this contract, they've been using contract staff. And so you will see here, we had in the early part of the year in January and February, quite a low percentage of the calls that came in that were actually handled. But overall, we track as a partner the percent of calls handled, the wait times of our calls, and the sort of the quality of the calls. And we have been averaging overall about this year 9,500 calls a month. That is an increase from the prior years, which the number was closer to 9,000. And I do think that was the increase this year has to do with the fact that they have had such a problem with staffing. So we are anticipating this sort of kind of the 9,000 a month call average. And I will say, you know, United Way has the option, you press 1 for English and 2 for Spanish, and they have bilingual staff available. Looking at the metrics in FY19 fiscal year, 34% of our callers chose the Spanish option, and we've seen a slight uptick to that this year with about 39% of the callers choosing the option for a Spanish-speaking representative. I've also just included for your reference, as we've talked about this, you know, our current contract budget amount for the United Way call center, and then I've listed to you what their staffing levels are under this contract. So COVID has really, we have been spending several months in conversation with community care and with leadership about the role of eligibility and sort of our vision in how do we continue to ensure that we are meeting our clients and providing the best service to them. And then, of course, COVID happened, and we realized, you know, prior to COVID, 70% of our applications were done face-to-face. And the remaining 30% were submitted to us through a community partner, like one of our clinic partners, the hospital, Austin Transition Center, or even community partners like Casa Marianela or Foundation Communities. Since March 23rd, our applications are now coming via phone, or, as you all are very well aware, we created an online application in order to provide a wider venue to allow folks to apply. And we want to continue that even post-COVID. And how do we look at giving multiple ways for our clients to get in touch with us and apply with us? We also realize that having standalone eligibility sites is not the most client-friendly way to proceed. And so you all may remember that as early as about 3 years ago, all of the central health eligibility sites were standalone sites. We had a site in South Austin, which shared the same building as Sendero, but the only function that the only service people could get in going to South Austin was an eligibility appointment. We had a site over by the BRAC campus. Again, it was at least physically near the hospital, but it was located independently in a site where the only service offered was eligibility. And then, of course, in our Northeast site, our largest site, again, it is a standalone, only eligibility service provided. And what we are trying to move toward is really incorporating our services into our clinic operations or locations like the sites we're looking at Eastern Travis County, where there will be an array of services available for our clients to not only apply for MAP, but to access food sources or apply for housing services. So that, again, is part of this vision. The other piece, and when we look at the call center structure, is the call center staff are trained in our policies and they have access to our eligibility database to view information. But when one of our members calls in and has a question about why they were pending on an application, the call center staff are reading a note, and if that note isn't abundantly clear, then they have to then sort of send us a ping to get back in touch with that client at a later time in order to answer their question. And so we find that though United Way has been a fabulous partner, not having them as internal staff, receiving the same training, going to the same meetings as our frontline eligibility staff, and being able to fully process every part of that application creates a mild barrier for our clients. And so we really want to create a sort of a larger eligibility staff that can be flexed. They can move to serve in the call center. They can also move to, if somebody is called out and we need somebody to go to an in-person site, they can transition to an in-person site. And we really can take our call center more to that one call resolution where they are fully addressing the needs of our clients when they call in. And as John mentioned, it will really allow us to expand on our outbound calling capabilities and allow us to quickly pivot and get information out to clients as the needs arise. And then the last bullet is one that I've already sort of addressed is, we have been over the last year really talking with community care about how we better maximize our resources. Community care has a call center and you push option 3 if you want eligibility information, and they have an eligibility team that schedules appointments to do application assistance. And how do we make sure that we are really streamlined and working together in an efficient way that is most beneficial for our clients? And so providing a co-location is kind of that first step in opening up those communication lines with community care and making sure we can maximize the services that we offer. This next slide just gives you a high-level timeline of our process of implementing a call center by October 1st. There's been a lot of work that has occurred in these last months in identifying furniture needs and looking at lease space and starting that negotiations. And then I'm excited to say that we actually have our call center positions posted currently. And it's unfortunate that so many folks are losing their jobs, but I will say it has allowed for a rich supply of applicants to come in for this position. And so we are in the process of looking at that. And I should mention to you all, many of you know Becky Huerta. She has been with Central Health for over 20 years she has been with the MAP program. And so with Central Health since its inception. She is our business process manager and has managed the relationship with United Way since we started in 2009. And she is going to take over managing our call center. And so we feel like we've got lots of great continuity there. And she is keenly aware of what we need in an eligibility staff person, but also in a call center person. So she has started that process in reviewing resumes. We look to have our staff on board in July. We'll do our construction once our lease is signed with joint tech and building out the space in the months of July and August. We'll have our staff trained in the months of July and September. Start our install of furniture and equipment, and are looking for a move-in date for our staff in mid-September so that we become fully functional on October 1. And currently, you all are aware, we have a 978-8130 phone number. It is a Central Health line that has just been ported over to the United Way. So that number will stay with us and will just be, it's probably not as easy as flipping a switch. I can imagine Sandy Simmons sort of smiling right now, but I'm going to say they're going to just flip a switch, and on September 30th, the calls will ring at United Way, and October 1, they will ring at our call center. This last slide here really talks about the action that we are asking for tonight. And that is the approval to negotiate and execute a lease agreement with Kuchera Management. It is for a Suite 170 in the Atrium Office Center. The size of the space is just over 6,100 square feet. We are looking for a lease start date of September 1 with an expiration of August 30th, 2023. This is a 36-month lease, and as John said, that really is the shortest amount of a lease that we could get. Stephen did an amazing job negotiating that down so that, it better aligns with when our lease expires for the existing second level office suites, and it gives us an opportunity to look at, are there better locations for the call center for a future lease, and gives us that time to make that transition. I've shared with you the initial price per square foot and the improvement allowance that has being negotiated. We have put in a contingency in the case that the $73,000 improvement allowance does not cover all of our need, then the remainder would come out of Central Health funds. In talking with Stephen and others, folks feel pretty confident we'll be close to that, and we are being very mindful of what improvements we put into place. But it is pretty much a blank slate, so there is there's some build-outs that will need to occur. And then we've listed for you the fiscal impact. Of course, the FY20 fiscal impact is the unbudgeted impact, and then FY21 forward will be put into the proposed budget and should be all of those costs then offset by the existing $800,000 that we are spending with the current United Way contract. And that ends the presentation. I'll go back to the former slide in case you want to refer to it and there are any questions.
Thank you so much. Thank you, John, and thank you, Kit, and thank you all of the staff who have worked on this. This is a very comprehensive review. And of course, we want to thank the United Way for its years of partnership, and we appreciate that. And I also want to commend all the staff who have worked on this for negotiating this deal and the 36-month lease, which aligns with our current space, and also for looking at ways that we can increase access to eligibility, multimodal, as I say, whether, the call center and other things that actually we've learned during COVID, And so we appreciate that, and some of the other ancillary services that you mentioned, to sign up for eligibility. With that, members, do you have any questions? You may have to shout out if I don't see you. Any questions, members?
Yes, I have one.
Yes, Manager Jones.
Yes, just a little information, Ms. Bellus. Could you help me understand? So the Eligibility Center, presently that's United Way, is that operated out of there? Where is that located now?
The United Way call center is embedded inside of their offices, which is just off of MLK. It's on East MLK.
Okay. Yeah, I'm familiar with that. I just wanted to make sure that was the same location.
Yes.
Currently, is that a walk-in, or pre-COVID, was that a walk-in facility?
No, the call center has never been a forward-facing opportunity. It is only received phone calls.
Okay, so our eligibility efforts, are they going to be unified in this one location, or they'll continue to be in the other locations as well as this?
We will continue to have forward-facing in-person eligibility at our current site. So Southeast Health and Wellness, we're at the Northeast Health Resource Center, again, post when we're out of COVID. We're at the Pflugerville Clinic once a week.
Okay, that answers the question. I misunderstood the pulling together. So you've answered that question. So thanks so very much. That was the only question I really had. Thank you.
Members, any other questions? I'm trying to scan. Yes, I think Manager Valadez, do you have a question? Manager Valadez? Manager Valadez, do you have a question?
Yes,
Okay.
thank you. Thank you for the presentation, Kit. And this space that we're talking about, that same space that I was originally concerned about for not having seen the lease when it was approved, over there northwest off of Mopac between Steck and 183.
Yes,
Can
ma'am.
you hear me?
Can you
I
hear me okay?
don't know
Yes,
who's responsible.
This is
John,
the
is that-
location at Mopac and 183. That's correct.
that is the space that was approved without us looking at the lease. So, okay. Now, is this going to be additional square footage in addition to what we have there in existence right now?
That's correct. So
Okay.
right now we have space on the second floor. This is additional square footage on the first
Right.
floor. The second floor space is for our staff as well as Community Care's Patient Navigation Center.
Right. So, are we going to have any space in the clinics at all? Because that really is the best place for some of the work
Yep.
to be done in a face-to-face.
Absolutely. And just to reiterate some points that Kit made earlier, that's really our goal. And this kind of goes back to Manager Jones' question as well. This is just the relocation of the call center function. We do have some changes that we need to make longer term related to our physical locations. As Kit mentioned, we want to move away from standalone eligibility sites and try to work with community care and embed eligibility into our clinical sites moving forward. So we'll have additional transitions there. But especially in this COVID environment, it's really forced us to look at our operating model and try to do everything we can to assist people with an online application and telephonic assistance. If we can avoid people having to come into an office, we're going to try to do that.
I appreciate
but
that.
Also, forward facing in the clinics as well as part of the goal.
Right. That's one of the things that I had suggested a couple of years ago. So I really appreciate you all looking at that, Kit, and bringing that to fruition. With respect to some of the phone calls that have been made, I personally followed two. This is just two people recently who had tried to apply for MAP, and I didn't know whether or not we were told originally that they were doing it online and they could do a telephonic application. for those people in our community, many of which are, of course, we all know, are beyond the digital divide and cannot get on a computer to apply online. You have to be empowered and a little bit computer savvy to be able to do that. And that doesn't happen oftentimes in our targeted population. So I have followed at least 2 people who called the eligibility line and were told that no applications, this is recently, within our COVID period, no applications were being taken care of over the phone. One of them is very disabled, and she told them, I even got on the phone and said, this person is not capable of, she doesn't have a computer, and she's not capable of maneuvering or navigating the system. Is there any way that someone can handle her application telephonically? And she was said no. She was told no. I was a witness to that on 2 different occasions, 2 different people. I just want to make sure, Kit, that we have, when they tell you at our call centers that they do not have a computer, they cannot go online, they have to apply on the telephone, that we're making sure that our people understand, our eligibility people, that they should be taking those applications.
So if I may ask a question, Manager Valadez, I certainly concur with you that the digital divide is real and digital exclusion is real.
Right.
Whether it is because people can't
They're
use
illiterate.
devices,
They're not very literate. Okay.
not literate or can't afford the devices, or
Right.
maybe
Financially impacted.
or maybe my father's age.
Yeah. They're having trouble with
So
the
Kit, what is the situation? Can people apply over the phone?
They absolutely can, and so I do
What's
want
going
to
on
say-
with the training?
Well, yeah, and again, and this is highlighting the advantage of having this be an internal function. Again,
That's
United Way
Yes.
has been a fabulous partner, but we don't have control over. So, but I would say, Manager Valadez, is if you could send me the names of those individuals, because we can pull calls, so we can hear the recorded calls. We can talk to United Way management and make sure that.
So let me ask Kit another question.
I will do that. And I just
Yes.
wanted to make sure that
Let's handle that offline, please. And
No,
we
no.
understand
I
that
just
you'll
wanna make
forward
sure-
that to Kit. But Kit, I think you're
Thank you.
pointing out something important, and that is if there are employees, then we can be on top of this and on top of the training and make sure that the right information gets out. When would this go into effect?
October 1.
October 1. So we need to ensure that between now and October 1, that people are getting the correct information. Thank you.
Exactly.
Members, any other questions? I'm scanning, trying to look for any hands, or just speak up if I don't see you. I'm not seeing or hearing any other members. This is an action item, so we do need a motion, members, if you want to move forward. there
Is the
anyone-
motion going to be recommended to the board for adoption, or is it going to be an immediate adoption of this lease agreement and the recommended action?
The committee would recommend that the Board of Managers authorize the president and CEO to negotiate and execute a lease.
So moved.
I have them. If you need me
Well,
to
you
read
have to read it.
I have it. Would you like me to read it? I have
Yes.
it.
Please. Thank you.
Julie.
I move that the committee recommend that the Board of Managers authorize the president and CEO to negotiate and execute a lease with the
Kuchera.
company for suite number 170 at the Atrium Office Center for the period of September 1, 2020 to August 30, 2023 in terms equal to or better than those presented.
Thank you. There's a motion. Okay, so there's a motion by Manager Zuniga. Thank you. And a second by Manager Valadez. Any discussion? Not seeing any hands or hearing any. So all in favor? Aye.
Aye.
Opposed, same sign. Okay. Abstaining. All right. I did not hear any opposition or anyone abstaining. Thank you, members. The motion passes. So we will now move
Thank you
to.
all.
Yes, sir. I hear somebody.
I think that
I
was
was just
Jonathan.
saying
Thank
thank you all.
you.
Oh, thank you. Thank you for your excellent presentation. We appreciate it. We will now move to item number 2, take appropriate action on a report of the May 2020 financial statements for Central Health. And you know what, I'm going to go ahead and read items 2, 3, and 4. 3 is take appropriate action on a report of the May 2020 financial statements for the Community Care Collaborative. And number 4 is receive a report on fiscal year-to-date healthcare service expenditures made by Central Health and the Community Care Collaborative. And Lisa Owens and Jeff Canota will be presenting on all 3 items. So please proceed.
Thank you. Good evening, Lisa Owens, Deputy CFO. So I'm going to walk through first the Central Health financial statements. I'm also going to, Manager Valadez had several questions 2 months ago, and I was going to address those in this presentation. Many of the questions that you had, the variances that you asked about are still not exactly the same number, but I can explain the variances with some context as I go through. So I'll hit some highlights there as well. So we are presenting financial statements through May. We are 67% of the way through the fiscal year. And our cash collection tax revenue, as you know, is strong as we have collected most of the tax revenue. We also have restricted balance in our LPPF as of 5/31 of about $39 million. So if we can move to the next slide, I will hit a few of the highlights on the balance sheet. As I mentioned, most of our cash is held with Travis County Investments and short-term investments, and that is a year-over-year increase of almost $80 million. A lot of that will be addressed in the conversation about the questions you had, but looking at where we've collected more sources than uses. So I will address some of those variances in the next couple slides. We did have total current assets of just about $240 million. And the year-over-year variance, again, driven by a strong cash position as of May 31st. No significant changes in our restricted for investments and non-current, with the exception of at this time last year, the LPPF did not have any funds. So you are seeing an increase of about $38.5 million, $39 million for the restricted for the LPPF cash and investments. And no significant changes, again, in our capital assets. Total capital assets as of May 31st are at $110 million and total assets at $508 million. Going to the next slide, our liabilities and net assets. You will see, again, pointed out several months in a row as we contracted for additional network providers in primary care, specialty care, and pharmacy, other areas that we'll get into a little bit later in the slides. As a result of additional contracted providers, we have additional accounts payable, and that year-over-year variance is driven by those additional provider payments. About $6.5 million of that $8.5 million is for accrued provider payments. We did also refund our bonds, so you will see slight changes in the debt payable schedules as we move into the end of the year. But as you will recall, when we presented that, the long-term positive impact is that there is a better interest rate, so there will be less interest. But we do have short-term debt service payable of $1.1 million. So total current liabilities are just under $15 million as of May 31st. Our total liabilities also include the $39 million in cash that is held for the LPPF and our long-term debt. And then our total liabilities combined short and long-term are just over $59 million. That leaves our net assets at $449 million, again, for total liabilities and net assets of $508 million. As we go to the next slide, the sources and uses. As you know, property tax revenue was all due January 31st, so we do have a little bit of revenue still coming in. We have our lease revenue from the downtown campus, which consists of both lease revenue from the 2033 fund in the current year to date, and then lease revenue from the garage and CEC lease on the campus. And then other revenue, which is primarily interest revenue. Again, with such a strong cash position, we have strong interest revenue. Total sources of funds in May were 1.2 million, and total sources of funds year to date were 292 million. And so one of the questions was about the year-over-year change of 30 million. So if you look at the last column on this page and the first bolded row, total sources, you'll see that at this time last year we had $262 million of variance of $30 million. That is primarily made up of the fact that we collected an additional $18 million in property taxes that was budgeted and planned for with the planned tax collection for this year. And then the contingency reserve carry forward, which, as you know, we estimate in the budget process in the summer. That number is calculated after our final audit, and that is carry forward of available sources of funds, and we ended in a stronger position by about $12 million last year than we anticipated. So moving into the uses of funds, we have a lot more information on the next slides about healthcare delivery and in the combined report. But just quickly looking at administrative, we do have $4.7 million in administrative expenses year to date, just up slightly year over year, but well within our budgeted range. Again, I mentioned we're at 67% of the year. We're at about 44% of our administrative costs. And then finally, our total uses. Another question that you had, Manager Valadez, was about total uses being down by $42 million. Again, year to date, our total uses is $102.8 million. And last year, at this time, it was 144.9. And that is driven by healthcare delivery expenditures. And so I'll go into those details on the next slide, that $42 million less spent year over year. And that combined result, additional revenue of 30 million and less expenses or uses of funds of 42 million, does result in the third question, which was around the 72 million, large variance year over year in our excess sources over uses. So we are at a strong position at $189.5 million. Last year at this time, we're at 117. Again, driven by additional sources of funds of 30 million and less uses of funds of 42 million. I will go to the next slide, which is healthcare delivery. I think you're already on that. If we could go to slide 7, Brianna, that would be great. So looking at slide 7, this provides a little more detail on healthcare delivery. And like I said, we have planned to spend about $278 million on healthcare delivery this year. Where you see the major variances is where we planned variances and changes this year. So significant decreases in our IGT. As of May, we made our final disproportionate share transfer. You might recall that the intergovernmental transfer calendars have been accelerated a little as a result of COVID in order to get the dollars out to the system as quickly as possible. That payment was made in May. So our total year-to-date IGT is at about $26 million. And our final IGT for the year will be in the DSRIP program. We anticipate that in July. Last year at this time, though, you'll notice that we had spent $77 million in IGT. Now that there is the LPPF, significant expenditure that is in the LPPF is the uncompensated care IGT. So that change is part of that variance. There was a question about a member payment. There have been no member payments by Central Health to the CCC. So looking at the member payment line, you will see FY20 year to date, there has been no member payment. And that there also is no member payment budgeted. And just proceeding down through the healthcare delivery, we're going to go into more detail on primary care and specialty care as far as year to date spend on the combined report, as well as you have some more backup slides. Looking at our total healthcare services year to date, we do have $41.4 million in healthcare delivery expenses. And last year at this time, again, a variance there, as we did not have many of the contracts that we have in Central Health last year at this time. Looking at the ACA premium and assistance and enrollment, that program has had an additional expenditure. We have had a full year of participation in the expanded high-risk program, and we also increased that enrollment this year. So there is a year-over-year increase of about $2.5 million. And we are on track. That is, it's about 62% of the budget, and we do anticipate that those premiums will be fully expended supporting the premium and the programs, and those are paid directly to Sendero health plans. And the healthcare facilities and redevelopment, we have not spent, last year in the budget, we had a lot of unknowns. We still continue to have a lot of unknowns in construction and the timing of projects, when they could start, projects that could happen on the campus, as well as other areas. So it's important to have budgeted dollars for consulting or planning work. And that planning work, I believe we did have significant consulting dollars in there for this year, and it has just not been spent yet. So we are at about 22% of the budget, and we will continue to plan in that way going forward. Healthcare delivery operating costs, those are the positions and departments that support healthcare services. Eligibility and enrollment is a large part of that, as well as many of you have seen the great reports from our QAP team, our quality team, and also other teams that are supporting healthcare delivery through internal departments such as operations and contracts management. The last row on this slide on 7 is that there is a year-over-year decrease, again driving that $42 million less dollars used in healthcare delivery, and that is in the debt reserves and transfers. And you will recall that last year, in our fiscal year, as of this time last year, we had made a transfer to Sendero of $20 million, and that was not budgeted or transferred this year. So that does make up a large portion of it, as well as an increase in our transfers to our capital reserves so that we can have the capital reserves available for projects as they arise. So again, looking at total healthcare delivery, we have spent year to date $96.6 million. And last year at this time, $139 million. Again, a lot of that driven through the IGT not being spent. Planned changes to the funding model are budgeted, as well as just changes in how we funded reserves and capital. So going to the next slide, I'll just quickly go through a little bit. I talked a little bit about our last IGT for the disproportionate share. We don't anticipate, other than continued chat, which is the catch-up payments in DISH, those small amounts for a lawsuit that was settled. But that was the final DISH payment for the year, and then we anticipate the DSRIP IGT payment in July. Our $41.5 million in healthcare delivery, you'll see that we have had significant expenses in primary care, specialty care, and our dental, and then pharmacy, both well over 50%. And we have a much more detailed slide about the types of specialty care that make up that $3.3 million in the specialty care. So quickly going to the next slide, I just want to hit on again, we have two separate programs, as we refer to them internally, in the ACA premium program, and that was another question that you had a couple months ago, and I just wanted to point that out, and I believe we also followed up with you about some data on the CHAP program. But year to date, in that $2.3 million that was budgeted for the CHAP program, which is the Central Health Assistance Program, we have paid $1.4 million in premiums, and those premiums do get paid directly to Sendero. And then again, as I mentioned, we have a full year open enrollment being in the fall. January 1st, we had new enrollment numbers for our ACA high risk program, and we are at about 59% of that budget. Again, $6.15 million of a $9.85 million budget in the premium assistance programs. And then finally, there was a question about reserves. We do have 3 reserves in our, we talk about this more in the budget, so you'll hear more about it, but we definitely have information. We have it outlined, the 3 reserves that we have: a capital reserve, an emergency reserve, and then our contingency reserve appropriation. And we calculate the contingency reserve appropriation at the end of the fiscal year, and we carry forward that for healthcare delivery services. Again, at October 1st, that was at $64.9 million. You saw that as a source of funds on the first page. And then as of May 31st, we did have $7.9 million in our capital reserves. And this year we have just around $38 million in our emergency reserves. I'm not going to go into the next 2 slides. I think those are the primary care and specialty care, as they are now combined together in the healthcare services report, but I'm happy to answer any questions about central health, or I can keep going through CCC and healthcare services, and we could do questions all at once. Manager Greenberg?
We might want to pause there because it's
Okay.
a lot to take in. Members, do we have any questions at this point? I'm scanning, but if I don't see you, just shout out to me. Not seeing any questions at this point. And if not, then we'll continue. Okay.
Great. Got a drink of water. I've been talking too much.
Good. Yeah, take a breath, please.
I know. Okay. All right. Moving on to the CCC. So again, just a few highlights from the CCC. We do have just under $10.5 million in cash and just over $11.9 million in total liabilities. So I'm going to go ahead and just go straight to the balance sheet, which is the next slide, page 3. Brianna, thank you so much. So again, we talked about this the past couple months. We do have a strong cash position in the CCC, just under $10.5 million in cash, a few small receivables, but the majority of our current assets are that cash at total of $10.8 million. We do have accrued liabilities, again, for provider payments, and the DSRIP program is part of not only the network of providers that we have in the CCC, but also the DSRIP providers that total just over $9.6 million. And then we have estimates in our deferred revenue and other liabilities. But again, total liabilities mostly made up of incurred but not reported or accrued liabilities for providers. That does put our net assets just at under $1 million, a negative $1 million. But as I mentioned last month and the prior, we have that current cash position that is strong, and we anticipate in July that the DSRIP revenue will come in well over budget. We've had another great performance here from our performing providers. So if we could go to the next slide, slide 4, we did for just over $61 million. We do anticipate bringing in over $61 million in July from DSRIP revenue. And so that was the only other source of funds that was planned in the budget for this fiscal year. And the timing on that is just not until July. And that was known. That is a known date that we've had from HHSC. We do have the contingency reserve carry forward. I think Manager Valadez, you had asked about that a couple months ago. That is an available source of funds. So those funds, just like Central Health, we carry those forward as available sources of funds. So those are being used for healthcare delivery. So then when you look at our budgeted uses of funds, it takes into account that available source of funds. So we have uses of funds in healthcare delivery, contracted providers, again, a little more detail available on the next slide for this, about $9.4 million. And then DSRIP project costs, again, that is $7.4 million. So just over $1 million negative net assets going into this May 31st, as of May 31st. And finally, slide 5, we do have a little more information. Again, this gets combined on the next presentation, but we have a couple of small primary care contracts, some specialty care in this CCC. We do also still maintain our inpatient contract in the CCC with Integral Care, significant contract to provide critical services for inpatient services. And then also the post-acute specialty line, post-acute care services, and that is just at about 70% of what was budgeted for this year. And then finally, our urgent and convenient care. The total for this healthcare delivery also includes in the $9.4 million our operating departments, and that is in total at about 48% of what we budgeted of our $19 million. So happy to answer any questions on the CCC.
Members, any questions on the CCC? And if I don't see you, please just shout out. Not seeing any questions or hearing from anyone. Get some more water, Lisa. Manager Valadez, did you have a question? You're on mute. You're still on mute. You're still on mute. Manager Valdez, you're on mute. There you go.
There, okay. Lisa, if you don't mind, if I can give you a call, if Mike will give me permission to do that, so we can have a conversation about some of those questions that I had from 2 months ago. I don't have my sheet in front of me. And then resolution here, and then for other questions. I'm not going to take up your time right now.
Thank you. Yes, let's handle those offline when you have your notes. Thank you very much. All right.
Okay, then the last few slides, we did take healthcare services by service line for year-to-date service lines that support our network of care to the patients that we serve in primary care, specialty care, pharmacy, and post-acute care, just to give that year-over-year comparison, which we think is important. So I wanted to just hit a few highlights. We are just at $31.3 million of our $52 million budget in primary care. Again, primary care services, you know, we do have a lot of unknowns, but we continue to switch to telehealth and provide those services in the clinics. It's been very successful, but that program, those services are offered in our network of primary care providers. And then our specialty care, we have an additional slide for that, but in pharmacy as well, I just would like to highlight the $6.2 million of our $11.6 million. And we've talked a little bit about this in the past. Year over year, that is significantly higher with the addition of MAP Basic, and also a little change in how we budgeted for that. Instead of budgeting for some of our partners in their primary care budget, we pulled it out because we think that's an important service line to monitor. And then lastly, the combined specialty care, which I see my colleague John Morgan is on. I think we have had great success by showing this year over year transactions to show that we continue to provide a steady level of care in specialty care, again, with a lot of unknowns around utilization and COVID. But we tried to highlight, again, for you, any significant variances. And one thing I'd just like to point out is we had a lot of new programs last year and the prior year, and it feels like from the financial statement perspective, we're really stabilized as far as providing a great set of specialty care, and that those numbers are a little more reliable. We do have a couple areas where we have not executed agreements, so you'll see no dollars spent, but those are in the works. I think urology is one, and we did have a couple new programs that we highlighted on the right that are just getting started in this fiscal year, wound care and nephrology. as well as podiatry. So the year over year, we are about at the same amount spent year over year at about $4.8 million in those specialty care lines with additional services being added. I'm happy to answer any questions about this report as well.
Members, let me see if we have, I see Manager Jones and then I think Manager Valadez. Manager Jones?
Yeah, I just have a quick question. Is reflected in here our cost with community care or our enterprise costs for COVID? Is there any place that we have a current running tally of what that is?
That's a great question. So we are, it's not drawn out anywhere specifically. We are tracking our expenditures in central health related to COVID, and community care is as well. So we can work on some reporting on that. A lot of it may be not showing up in a way that I think that you'd like to see it, maybe, which would be the combined impact. So let us work on that. That's a great question.
Okay.
It is a great question, and I think it would be good to see it as a separate and combined. So separate for central health and community care, and then combined. Would that suit your needs, Manager Jones?
Yes, the report was very good. I just was trying to monitor as you go through there. Is that reflected? But I understand what you're going to do. If you get back with us, I'd appreciate it. Thanks very much.
Thank you. Manager Valadez, did you have a question?
No, well, yes, I do. But I wanted to thank Manager Jones for bringing that up, because that's a question that I've had for the last few months. What is the budget impact on community care and on us? And then cumulatively, what are we going to have to do to resolve that in this upcoming, as we face an upcoming budget discussion? So I appreciate that disaggregated and aggregated data. But just a general question with respect to specialty care. As we talk about wound cares, we talk about urology and nephrology and all of that. Unfortunately, I'm living in that world right now. And one of the things that I brought up to our CEO, Mike, is that I don't see anything that addresses overall the provision of counseling service, let's say to someone who has had to have an amputation, someone that has had a significant life change as a result of diagnoses or renal failure or amputations or whatever, any of that information. And I don't know whether that's actually, I know in a hospital setting it is not provided at all. I know that at the clinic it is not provided at all. So I'm wondering, where is that, or is that something in anything that we provide, or is that something that integral care has to be brought in?
Manager Valadez, I see John Morgan wants to address that. John?
Is that something new?
John?
Manager Valdez, that's a good question. It's not completely clear in the way that we report the financials, but the majority of behavioral and mental health for us happens in two places. One is through the inpatient psychiatric services and other crisis support services through integral care. I know that's not what you're addressing here, but just wanted to acknowledge that's a big piece of the system, as well as in our primary care agreements, which is where the majority of the counseling, therapy, and psychiatry happens. It's not called out specifically as its own line in the financials, but it is a significant part of the primary care agreements, and that's one of the reasons those items are so large in financial terms. It includes medical, dental, and behavioral health costs in our primary care settings.
I appreciate that, but if someone can offline, Jonathan, if you can show me where and how that process and those services are being included and covered for our patients, and how do they access those? Because I haven't seen it. Okay, thank you.
Understood.
Chairperson Greenberg?
Yes, sir.
Charles Bell, you.
Yes, Manager Bell, please.
You have two motions to accept these reports, and I'd like to make both of them.
Please proceed.
I move that the committee recommend that the board accept the report of the May 2020 financial statements for Central Health And I further move that the committee recommend that the board accept the report of the May 2020 financial statements for the Community Care Collaborative.
So, thank you. Manager Bellus made 2 motions. I see Manager Valadez. Are you wanting to second those? Can you?
Yes, yes.
Okay.
A second.
So, and seconds by Manager Valadez. There's no more discussion. All those in favor say aye.
Aye.
Opposed, same sign. Any abstaining? Okay, I don't see any in opposition or any abstaining, so the motion's passed. Thank you very much, members. Okay, we will now move to item number 6 on our agenda. Discuss and take appropriate action on a process for the Central Health Board to receive, prioritize, and decide on funding requests from outside organizations. Mike Giesland will be presenting. I'll turn it over to him. Thank you.
Yes, thank you very much, Madam Chair and members. Members, there's a memo in your packet that went out in advance of the meeting, and I'll speak from it. I won't read through it line by line, but the first, set the backdrop for this as we go into the budget season, and this is not uncommon, but in prior years, we receive requests from outside organizations for funding. Sometimes it's just what they're looking for is a direct allocation as a source of revenue for them. Sometimes it is for a very specific purpose. And then the amounts range anywhere from a few tens of thousands of dollars upwards of high levels of 6 figures. And so what we don't have is a formal structure to properly look at these types of outside requests within the framework of access to care and addressing health inequities. And so what we're presenting here tonight is just that framework. And to summarize the issues that need to be resolved, you can distill them down into 3 distinct issues. One is an efficient manner for handling these funding requests. 2 is the equity in handling such requests. I think within the framework, again, as we mentioned, access to a system of care, rather than relying on just straight up political request or maybe a first in line means of asking for funding. And then the third issue that needs to be resolved is giving the board some flexibility as you think about funding services, not unlike how you fund primary care or specialty care or post-acute care, that will address a prioritized health inequity, quality issue, or a systems gap. And so what we're recommending here tonight, and what we're asking the committee to do is support a management recommendation that then will go to the full board, and then it'll be formalized and put into the budget resolution. Now, just a quick note on the budget resolution. You'll recall this is a document that is approved along with the budget and the tax rate. And in the past couple of years, we've been using it as one of our foundational documents to link together the budget, but also the strategic objectives that have been established by the board and the sub-objectives underneath those larger objectives. So this is an important document that aligns budget and strategy. And so taking an approach that is used in state budgets where you have a rider, we don't have to use that word, we can just call it a provision within the budget resolution. It would establish the creation of business cases and the criteria for submitting those business cases, and those are spelled out in the memo that's in your packet. This set of criteria would then be approved by the board, and then any future investments or expenditures from the allocated funding, they would also be approved by the board. So it's not, so you get 2 opportunities: 1, the framework, and 2, the actual investments that are made underneath that framework. The third thing that I'll mention about this approach is it is contingent upon sufficient revenue being available to fund a line item in the budget. We've put a working title for this allocation of funding as Community Healthcare Initiatives Fund. It'd be a line item in the budget so everybody could see it. But then there would be some very specific instructions with how those funds were to be invested or expended relative to board action. So again, there's a memo in your packet, and I'll pause there, and I'll be happy to answer any questions and call upon others as well that helped in the creation of this concept.
Thank you. Members, any questions? I certainly do think that we need a a process, and I think that this process that you propose, which we don't have riders, but is similar to a rider, is one that I have seen work well in other venues. So members' questions, Manager Jones, and then Manager Valadez.
Yeah, I think that's a great idea. I think certainly I know the demands that have been put upon the agency to respond to all these would hopefully would give a framework in which agencies outside of us would be able to approach us. But like all things, the interpretation of those definitions are going to be critical. So as we look through the definitions of what we identify agencies can apply for or meet, who would determine, will that be determined by the board under your memo here?
Should be.
Ultimately, yes, sir. So you'll approve the framework, and then any investments or expenditures from that line item would then secondary and subsequently be approved by the board.
So just as House Appropriations and Senate Finance would if we were at the Texas legislature and looking at the legislative appropriations request and the appropriations bill, right?
Right.
It would ultimately rest with the board.
But as in the case with, I'm not familiar with legislatures as much as council, is that those departments that validated those or took it forth or supported those had a lot to play in that interpretation. So the question I raise is that will the public or the agency have an opportunity to appeal should they not come forth from the CEO to the board for funding?
Manager Jones, I'm not sure I understand your question about an appeals.
Okay, so let's say agency X wants said they met the expectation based upon their interpretation of our definition, and it got to the executive staff and said, no, we don't think so, so we're not going to put it forth to the board. Then the agency comes back to the board, or the organization, nonprofit, or whatever, come back to the board and say, well, we think we should have gotten the funding, and it's never it didn't get to the board. That is just a very general scenario. How would we handle a scenario like that, I guess is what I'm asking.
Right. Members, if I could draw your attention to the memo that's in the packet. It's on packet page 56 of 60. And if you look on the second page of the memo, there's and I would consider this to be a starting list, and it could certainly, it's ultimately up to board approval. But if you think about the elements of the business case, it lists the criteria for alignment with Central Health's mission, clear demonstration that the proposed services will address a systems gap or a quality issue that improves access to care. And I won't read through all of these. Diversity of leadership and staffing, projected outcomes. These are the sorts of things that, as a board, you can control the criteria, and that ultimately determines, okay, what is it that comes back to the board? Now, as far as an appeals process, this document or this memo right here didn't specifically address that. But if you think about the way that the board decisions would be made on this, first of all, you're not doing it in the confines and under the pressures of actually having to adopt this budget. This is something that would happen during fiscal year 21. And so you get this criteria developed. So through the natural process of making these decisions in an open meeting, you would have that opportunity for individuals to come in and say, look, we didn't meet this criteria, but we still think you should fund us. Now, the board can make that kind of decision, but what we're asking you to consider is, how does that tie back into access to care, or us deliberately addressing a health inequity? And so that's ultimately a decision that's made by the board, but we don't have a formal appeals process built into this.
But I don't. But since the decision's ultimately made by the board, people could sign up for public communication, but also board members on their own, I would think, could bring up these things, because the decision's going to be made by the board. Correct, Mr. Giesland? That's correct, and I do think the board should have line of sight into everything that has come in under this. I'm just going to call it a program or framework, but you should. We would see all the requests. The board would see all the requests that have come in, right? Okay.
So we would see all of the requests.
Yes.
And a vetting process would go on through administration, and then the board would have the right at some point, should that vetting process result in an agency not getting funding, to be able to bring it back up again.
Of course.
That's the
Okay.
board's decision, yes.
Manager
I just wanna make
Valadez?
sure. I want to make sure.
Manager Valadez, and then Manager Musaitif, did you have a question? Okay. Manager Valadez, do you have a quick question? Because then I want to move to Manager Musaitif.
Let her go first. And mine's actually
Okay.
long. I'm trying to condense it in my mind.
Okay, let's do that. Manager Musaitif?
Well, thank you, Chair. Appreciate it. Thank you for this memo. I would like to see us somewhat link it to our Health Equity Council, because we're already doing some of this work, and some of the work that has been done, there's not recommendations, there were not any kind of funding allocation. I'll give you an example, the recess policy that we had. It was a great initiative, but a lot of schools, there was barriers. They didn't have any funding for whatever reason they wanted to expand recess access. So there's kind of a linkage between the programs that we have in existence with this future funding. So thank you.
Mr. Giesland, certainly in the memo that's outlined, it appears to me that that would be the case, that you would be looking to our ongoing efforts and priorities and such. Would that be correct? Or Monica, if you want to address that?
Well, I'll start off, and then Monica, I'll ask you to provide some commentary as well. As you can see by the criteria, we're being very, very deliberate about this. And members, I'll ask that you strongly consider what we're saying here. We're trying to link these things to an access to care issue or to a larger systems issue where there is a disparity or an inequity that we know we can effectively and meaningfully address. And I think when you think about things that are coming out of the Health Equity Policy Council, Manager Musaitif, those are typically policy issues. And sometimes those policy issues get implemented at the city or the county level, or sometimes the state or the national level. But I think this is really focused on services that come in and fill a gap in our systems or in access to care. And I'll pause there because I know I'm
Give me an example.
So for example, if there is let's say there's an organization that provides a healthcare service that is maybe not something that is currently being provided within our system, and it is done in a more culturally appropriate way. And it addresses what is statistically a health inequity. And it could be low birth weight. It could be the prevalence of diabetes. And there is a unique approach. And let's just suppose that there's a business case that's put forward and it meets all the criteria that the board has set forward. Then that obviously is something that would become part of our system of care. And I know that we've looked at this in the past, and this is another approach that could also be taken. If it could be part of and embedded in our care systems, our FQHCs, for instance, our specialty care, our post-acute care, then all the better, because then you can better align the overall access to care and strategy approach. Another example would be, let's just say a group says, we'd like you to fund our advocacy efforts around, fill in the blank, anything. That is obviously a noble and worthwhile cause and endeavor, but it doesn't come in and address a system access issue that we have. And when you think about a healthcare district and providing access to care and creating health equity in these systems, then, if you had a business case of somebody that could address that with a direct service, then we would need to look strongly at that. So I'll pause there.
Well, thank you, but I still feel that the Health Equity Policy Group can really have some say in and weighing into this. You can probably expand their work because in terms of policy, yes, it may be city level, but it can also be policies that we have within our organization and our partners. And funding sometimes is very critical. So this is an opportunity that we can expand on.
Yeah, so I understand better now, and so thank you for saying that, because I do think, for example, if you take the Health Equity Policy Council, we met with them today, there are some suggestions and guidelines that could be built in as the overall policy framework for addressing health inequities. And I think that could very much
Thank
be
you.
part of this process.
Thank you. Members, any other questions? Speak up. Manager Valdez, do you have your concise question now? You're on mute. You're still on mute.
Am I off? If I'm
Yes.
am I unmuted? Okay, thank you. Mike, I appreciate this. When I was reading the elements of the business case, they sounded very familiar for something, a resolution that I tried to submit a couple of times at least, and it didn't go anywhere because it felt like this language was very similar to what I had suggested. But before we get to that point, I feel that it's important that what we do is we have public and community input into the development of this, how it would work. I fought very hard to create the city equity office and for the creation of an equity officer within the city of Austin. And we did that through the Hispanic Quality of Life Commission and the public. So with respect to this, since it is going to be tied strategically or tied to our strategic plan and budget, I personally would like to see a community forum, some opportunity created so that we can talk about this. And then if there is an RFP that needs to be developed, then we create an RFP so that we can look at how that implementation will occur with everybody having an opportunity to provide input and having it vetted in the community. I think that's a much more transparent way and an open, that's for me, transparent access from the bottom up, and it's a way of doing business that we have committed to.
All right, Manager Valdez, thank you. Let me just interject something though. It's in line with what you're asking. I understand what you said about an RFP, but I think we tried that. And I think the issue here, Manager Valadez, is that we get these requests out of the blue that don't come from an RFP. And so we're trying to deal with those ad hoc requests that we get that. Is that right, Mr. Giesland?
Yes, that's correct. And they don't come through our provider partners, for instance, or sometimes even through any kind of analysis on the data that we've done. So they often do come out of the blue, yes.
So Manager Greenberg, just so you understand where I'm coming from,
sure.
When we started having these conversations about this, I know I did with Mike, it was coming from the perspective of looking at what's our strategic plan, looking at where the inequities exist, where are those gaps, how are we going to fill those gaps? Again, you know, setting up an evaluation form of those.
Right, I remember that.
All of that information, much of that is included in this. However, I really do believe that we should have a forum, some kind of open forum to talk about.
Let me ask other members. Manager Valdez, let me just see from other members if there's a belief, and I understand the goal of transparency, but I want to see the sentiments of other members. Manager Zuniga, did you wish to speak?
I thought you were going to ask us. I think it's a great idea for us already to let people know what we're going to, our priorities. I think the document's super clear, and I like what we already have. I don't see a need to have input.
Thoughts from other members? Yes, Manager Bell. Manager Bell, you're on mute.
I'm not quite understanding what Manager Valadez wants to do. From what I understand of the process is that we would have criteria. The individuals requesting funding would tell us where in that criteria their funding fits. We as a board would review what staff presents to us, and we would fund that. Now, are you asking that we go to the public first before we make a decision? Or are you asking that we go after we make a decision and let them know? I'm confused.
I'm very clear in what I'm stating. I'm sorry.
Well, you may be clear, but okay. I'm not understanding.
Okay, so what we need to, we have known about the disparities gaps and the system-wide gaps that exist in Central Health forever. This is not anything new. This is, I appreciate that this is the first time that we're actually giving it some serious weight and discussion. In light of that, what I am asking for is that there be a community forum so that we can talk about the systemic changes that need to occur to Central Health to address those gaps and inequities. Those have to have been created. That information needs to have been provided first so that they'll have a baseline from which to provide input. After that, then we see an alignment plan so that we can fill those gaps. Then we have to create a process by which organizations will be submitting their requests for funding based on where it fits in those alignment gaps that we need to try and address. And so all I'm asking for is that we do it from the bottom up and not approve this, especially when we're talking about it being funded from our tax rate, not knowing whether it will or will not fit in line with our strategic plan and budget priorities.
Right, and Manager Valadez, I understand what you're saying, but the problem we've had when we tried this in the past is that not everyone will adhere to that process. There will be people who would submit requests to us ad hoc, and so we're trying to address that here. As far as going to the community, I totally agree, and I think we're doing that through our budget process. Mandrew Musaitif, I think I saw that you wanted to speak.
Yes, I really concur with Dr. Bell and Manager Zuniga as well said. And I'm really hoping that we can act and move things forward. And I believe we're making it very transparent. We're trying our best, but having these multiple meetings will not really move us further along. We need to be able to get things done. And so that's really my hope. Let's just get the work done. Thank you.
Anyone else? Before I get back to Manager Valdez, was there anyone else who had Manager Bell?
Well, and I also want to say that the public is also invited to all of our meetings, our strategic planning meetings. I mean, if Manager Valadez has a invite list that she would like to go out and invite people to our Eastern Crescent and our strategic planning meeting to come in and see what we're talking about, I would welcome her to do that. But to try to make these separate meetings, really and truly, I don't know that we're going to come in for our budget on time to be able to have a budget for next year.
Well, it's my understanding.
Hold on, Manager Valadez. Is there anybody else before I turn to Manager Valadez? I'm just scanning. Speak up if I'm not calling on you.
No questions for me.
Okay. No one else? Okay, Manager Valadez.
That's okay. I know how to count. Thank you.
I have a question, Chairperson.
Yes.
So is the ask of us tonight to support the recommendations in this memo to be inculcated in our systems of reporting, of letting the community know, are these are the criteria or the systems we're going to be looking for, they need to meet in terms of seeking funding from us?
Mr. Giesland? Mr.
Yes.
Giesland will respond.
Yes, all we're asking tonight is that if you could support the management recommendation that's in this memo and advance that to the board, and then the full board can then ratify or approve this rather. That's request one. And then the second step would be to start formulating this so that it can be included in the budget resolution to address the systems and the health inequities that we previously talked about and that you brought up in your question.
Okay, anything else, members? If not, does anyone want to make a motion?
I'll make the motion.
All right, Manager Musaitif.
Just want to had it pulled up. And this is the...
This is item number 6.
Okay,
Yes,
I move that the committee recommend that the Board of Managers approve the process recommended by staff for the Central Health Board to receive, prioritize, and decide on funding requests from outside organizations.
I
Manager
second.
Mopac, Manager Bellus seconds it. Is there any further discussion?
One quick question. So on that recommendation, it talks about moving this forward to the board.
Right.
Then the second part of what Mr. Geisler was talking about is what goes into what those criteria. Is that going to be a separate process?
Yes, sir. And let's just, if the full board approves this, then by March 1st of 2021, we will have what we call an alignment document. And this is spelled out in the memo that's in your packet there on page 2 under the recommendations. And then the board will need to approve this alignment document. And what that does is it sets forth the elements for making the business case and the funding that would then be invested underneath what we're calling the Healthcare Initiatives Fund.
Mr. Giesland, if I'm understanding this right, this is a recommendation that would come before the full board. If the full board approves it, then there would also be, you would come back with further details. Is that correct?
Yes, that's correct.
Now this will be refined more. Manager Valadez?
I just wanted quick clarification from you, Mike. I want to make sure that I'm understanding that we will be receiving a budget recommendation for this process, the funding of this process. Are we going to see that before we vote?
Yes, and if you look in the recommendations, again on page 2,
Yes.
on item number 2, it says correlate an incremental increase in the property tax rate to generate a fixed funding allocation amount to fund the initiatives. Absent final approval of a tax rate that does not contain the correlated incremental increase, the fund will not be created. And again, what this does is it's a, you can look at it 2 ways. It makes sure that there is a source of funds for this, but then if one is not created, then those initiatives that who knows how many it'll be, and they would not have a funding source for those unless they were partnered up with maybe one of our clinical primary care or specialty care operators.
One more clarification,
Yes.
Madam Chair.
Yes.
So Mike, with respect to the budget development and provision and it being provided to us, we would also be able to see or to have it language included there that this was actually going to tie to our mission, to our targeted population, and to the disparities gaps closure with respect to our continuum of care and the
Yes,
healthcare system that
yes.
we are operating.
Yes, ma'am, and that's all contemplated under paragraph 3, subsection C.
And it's part of the budget resolution. Is that right, Mr. Giesland?
Yes,
Okay,
ma'am.
members, we have a motion and a second. All in favor, say aye.
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 Any opposed? Any abstaining?
I'm going to abstain for right now.
Mandrew Valadez abstains. I did not see any in opposition. So thank you, members. A wonderful discussion. We will now move to item number 7. Discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease, including next steps in the redevelopment of the Central Health downtown campus. I announce that the board is convening in closed session to discuss agenda item number 7 under Texas Government Code section 551.071, consultation with attorney, and or section 551.072, deliberation regarding real property. Members, you need to completely sign off of this Ring Central. So get out of this meeting, close and leave this meeting, and then you received information on how to get to the call for our closed session. So I will see you there. Let's leave this meeting. Okay, I see it populating. Let's see, I'm scanning. So I see Manager Bell, Manager Musaitis, Manager Jones, Manager Valadez, Manager Zuniga.
We have legal counsel.
Yes, we have legal counsel. I see. Do we yet?
Yes.
Okay, yes, I see. Are we waiting on Manager Zamora? Do I see
Yes.
Manager Bell yet? No.
Looks like we're
Oh,
missing-
thank you. Yes, please wave. I'm trying to scan. I don't know if he was rejoining us or not. Does anybody know? I know we have a quorum. Is that correct?
Yes, ma'am.
Okay, given that, I think I will proceed. So we have ended a closed session. It is now 7:45, and we ended closed session on item 7, discuss and take appropriate action on Central Hub owned or occupied real property and potential property for acquisition or lease, including next steps in the redevelopment of the Central Hub downtown campus. There is no action or motion necessary on this item. So that brings us to agenda item number 8, confirm the next regular meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee meeting is tentatively scheduled for Wednesday, July 15, 2020 at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. Members, at this time, I'm ready to accept a motion for adjournment. Manager
Move to adjourn.
Valadez, is there a
Second.
I'll second.
Manager Musaitev? All in favor? Aye. Opposed, same sign. Abstaining? Thank you, managers, for your attention in this very productive meeting. And thank you, staff, for all of your help. And for those staff who are not present, thank you. All right.
Bye.
Bye-bye, everyone.
Thank you.
Good night.
Good night.